Fakultas Kedokteran Gigi Universitas Hasanuddin secara resmi didirikan berdasarkan keputusan Rektor Universitas Hasanuddin dan keputusan Menteri Pendidikan sejak tahun 1983. Saat ini, peminatan terhadap Fakultas Kedokteran Gigi Universitas Hasanuddin semakin meningkat dari tahun ke tahun melalui jalur reguler dan internasional, sejalan dengan program World Class University. Hingga saat ini, Fakultas Kedokteran Gigi Universitas Hasanuddin telah menghasilkan ribuan alumni yang telah tersebar di seluruh dunia demi meningkatkan ilmu dan keterampilan, mengabdikan diri kepada masyarakat, mulai dari kota hingga ke pelosok negeri. Program studi kedokteran gigi Universitas Hasanuddin telah terakreditasi A untuk tahap sarjana dan akreditasi B untuk tahap profesi berdasarkan pada keputusan LAM PTKes. Program studi ini ditunjang dengan sarana dan prasarana seperti e-library Fakultas Kedokteran Gigi Universitas Hasanuddin, 33 ruang tutorial, 3 ruang kelas internasional, serta 3 aula. Ruang laboratorium, USC Center, ruang CBT, ruang jurnal dan unit production house, ruang dental education unit, serta bekerja sama dengan Rumah Sakit Gigi dan Mulut Pendidikan dan Rumah Sakit Pendidikan Universitas Hasanuddin. Program studi sarjana kedokteran gigi dan program studi profesi kedokteran gigi memiliki visi sebagai pusat pengembangan ilmu pengetahuan, teknologi, dan riset kedokteran gigi yang bersaing di tingkat nasional dan internasional dalam bidang pendidikan, penelitian, dan pengabdian kepada masyarakat dengan berbasis benua maritim. Misi yang diemban oleh program studi pendidikan dokter gigi, baik tahap sarjana maupun profesi, adalah meningkatkan mutu pembelajaran berbasis kompetensi dengan metode student-centered learning dan menyediakan lingkungan belajar berkualitas untuk pengembangan kapasitas pembelajaran yang inovatif dan proaktif. Menumbuh kembangkan ilmu pengetahuan, teknologi, seni dan riset dalam bidang kedokteran gigi. Menerapkan dan menyebarluaskan ilmu pengetahuan, teknologi dan seni kedokteran, serta tanggap terhadap perubahan dalam rangka meningkatkan derajat kesehatan gigi dan mulut masyarakat. Usaha tersebut dilaksanakan demi mewujudkan tujuan akademis, yaitu untuk menghasilkan dokter gigi yang berkualitas, profesional dan bertanggung jawab, membangun karakter peneliti bagi dosen dan mahasiswa, serta kerjasama keduanya dengan memberikan dukungan maksimal pada setiap keikutsertaannya pada kompetisi karya ilmiah, serta menerapkan dan menyebarluaskan ilmu pengetahuan kedokteran gigi untuk masyarakat.
Fakultas Kedokteran Gigi Universitas Hasanuddin terbentuk sejak tahun 1983. FKG Unhas dengan visi Pusat Pengembangan Insani, Ilmu Pengetahuan Teknologi, Seni dan Budaya yang unggul di bidang kedokteran gigi dengan berbasis benua maritim. Kami terus melakukan upaya pengembangan diri sehingga saat ini FKG Unhas mempunyai 9 program studi. Program studi tersebut adalah program studi sarjana kedokteran gigi, program studi profesi dokter gigi, program studi pendidikan dokter gigi spesialis prostodonsi, program studi pendidikan dokter gigi konservasi, program studi pendidikan dokter gigi spesialis periodonsi, program studi pendidikan dokter gigi spesialis bedah mulut dan maksilofasial, program studi pendidikan dokter gigi spesialis ortodonti, program studi pendidikan dokter gigi spesialis periodonsi, dan program studi program magister ilmu kedokteran gigi. FKG Unhas saat ini mempunyai dosen tetap sebanyak 88 orang yang terdiri dari 20 orang guru besar, 19 orang lektor kepala, 27 orang lektor, dan 22 orang sebagai asisten ahli. Untuk mendukung kegiatan proses pembelajaran, FKG Unhas mempunyai ruang-ruang kuliah yang memadai, ruang seperti ruang CSL, ruang praktikum, ruang OSCE maupun ruang CBT. FKG Unhas juga bekerja sama dengan 2 rumah sakit pendidikan. Yang pertama yaitu Rumah Sakit Gigi dan Mulut Pendidikan dan Rumah Sakit Pendidikan Universitas Hasanuddin yang telah terakreditasi paripurna dan sudah ditetapkan sebagai rumah sakit pendidikan sebagai tempat wahana pendidikan FKG Unhas.
Seiring dengan kemajuan ilmu pengetahuan dan teknologi, program pendidikan dokter gigi Universitas Hasanuddin terus mengembangkan diri serta menjawab segala tantangan dalam memenuhi kebutuhan sumber daya manusia di bidang kesehatan gigi dan mulut di Indonesia adalah melahirkan lulusan yang berkualitas secara profesional yang mampu memberikan kontribusi konkret demi tercapainya peningkatan mutu kesehatan gigi dan mulut masyarakat di Indonesia. Dan sesuai visi program pendidikan dokter gigi Fakultas Kedokteran Gigi Universitas Hasanuddin yang berstandar internasional menjadi pusat pengembangan ilmu pengetahuan, teknologi, dan riset kedokteran gigi yang mampu bersaing di tingkat nasional dan tingkat internasional dalam bidang pendidikan, penelitian, dan pengabdian kepada masyarakat dengan berbasis benua maritim Indonesia. Untuk menghasilkan dokter gigi yang berkualitas, profesional, dan bertanggung jawab sesuai dengan insan cendekia berkarakter maritim, Setiap tahunnya, kami selalu berupaya melakukan pembenahan sistem pendidikan dengan mengimplementasikan standar kompetensi dokter gigi Indonesia ke dalam kurikulum yang komprehensif dan bermutu tinggi dengan luaran yang terukur.
Program studi pendidikan dokter gigi terdiri atas 2 tahapan, yakni tahapan akademik dan tahapan profesi. Tahapan profesi merupakan lanjutan dari tahapan akademik. Penerimaan mahasiswa profesi dilakukan pada tiap periode yudisium tahapan akademik. Aktivitas mahasiswa tahapan profesi diawali dengan orientasi penerimaan mahasiswa profesi selama 2 pekan. Selanjutnya, mahasiswa akan menjalani kegiatan tahapan profesi selama 4 semester pada 9 departemen, yakni 8 departemen berbasis klinik di rumah sakit gigi dan mulut dan 1 departemen berbasis masyarakat. Kompetensi yang harus dicapai oleh mahasiswa profesi sesuai dengan standar kompetensi dokter gigi Indonesia yang dijabarkan dalam kurikulum tahapan profesi dengan penerapannya mengusung program One Visi Departemen. Kegiatan pemberian klinik tahapan profesi dokter gigi didukung oleh kualitas rumah sakit gigi dan mulut pendidikan Unhas yang sangat memadai dan terakreditasi paripurna. Penjaminan mutu pada program pendidikan dokter gigi dilakukan secara berkala, meliputi proses monitoring dan evaluasi, yakni menilai proses pendidikan serta fasilitas yang tersedia oleh gugus penjaminan mutu yang dilakukan setiap semester. Mahasiswa yang telah menyelesaikan tahapan rangkaian kegiatan pendidikan akan mengikuti uji kompetensi mahasiswa program profesi dokter gigi.
Bergabung bersama Fakultas Kedokteran Gigi Universitas Hasanuddin, program studi pendidikan dokter gigi demi amal padu mengabdi.
Assalamualaikum, Dr. Isra.
Waalaikumsalam, Dok.
How are you today?
Perfect, thank you. I see that Dr. Theodorus is already here with us.
Oh, good morning, Dr. Theodore, Dr. Hedwin.
Dr. Hedwin. Good morning, Doc.
Hello. Yes.
How are you
Hello,
today,
hello.
Doc? Dr. Hedwin?
Good. Okay. Let
Sorry, thank you
me
for being here with us, Doc.
quickly.
Yeah, I
Yeah.
haven't seen Stefano with us, but I think we still have 4 minutes left.
Okay.
How's Surabaya, Dr. Hedwin?
Sorry.
Surabaya?
Yes, I'm in Surabaya now. Yeah.
How's Surabaya now about pandemic?
I think Surabaya is slightly better, but still the load is still very high everywhere.
Okay,
Yeah.
alhamdulillah. About the case,
Yeah.
it's still increasing?
Yeah, still a lot of new cases. Yeah, I think it's not decreasing, still in the peak, perhaps. Okay, wait. I'm looking for the virtual background. Okay,
Yeah.
this is the one. Okay, good.
Dr. Ernie, I think you are use your
Oh my God, I didn't
virtual
realize, sorry.
background. So many events that you handled.
Give me some time and you.
Okay. Dr. Ivan says that his computer is installing updates. He hopes the updates installation finish soon, so that he can join it soon. Yeah.
We have 2 minutes left for start or begin this event, Dr.
And
Ernie.
I haven't seen Prof. Mushroom as well. Let me email him.
Okay, Doc.
Well, it's already 9, but I think that's a problem with Zoom because you need to upgrade it quite often.
Dr. Ivan said he will join us in three minutes or so.
Okay, perfect.
Yeah.
Because we still need to wait for our vice rector.
Yeah.
So are you work from home also, Dr. Hedwin?
Yes.
Are you
The clinic was my patient appointments are as announced by this is Dr. Ivan Stoyanov with the International Association. So I postponed all the appointments during the lockdown period.
okay?
Yeah.
So, and how
There
long?
are some control patient. Yeah, but it's not urgent, right? So I have some like oral lichen planus patient control. So I just postpone it and just give consultation by teledentistry during this control period, during this lockdown period.
Okay, I see that Dr. Tojano. Good morning, Doc. Or good evening for Cleveland time.
Yeah.
I think he's still preparing himself.
Hi.
Hello. Oh,
Good morning, Dr. Stoyanov.
Hello, good morning.
Maybe
Thank you all for
good.
your patience.
oh, it's okay. We're still waiting for our vice
Vice Rector.
rector, Doc.
Yes.
I hope you don't mind. And thank you so much for your very valuable time. I understand that it is night at Cleveland at this moment.
Yes, it's my pleasure to be with you all. Thank you for allowing me to speak.
And how your school going on with this pandemic situation, Doc, if you don't mind me to ask?
Well, we have been all Zoom for our lectures until now. And next week, we go back to in person. There was actually a requirement that our university made that everybody needs to be vaccinated to be on campus. And so the university is trying to enforce this and return everything back to normal. How about for you all?
I think we have the same situation at this moment, Doc. We try to get back our student to face meeting because it's quite hard to do it online, especially because in dentistry we need a lot of working with the patient, so they need to see patient directly. It's quite hard because even though with vaccination rate increase, but we still have some infection as well as mortality of these infected people still increase. So yeah. We just try our best this moment.
Yeah, I'm sorry to hear about the infections. I see that in the news over in Indonesia, which is sad.
Nah, we're lucky that until now, I think WHO still help us to reduce this number, and they haven't isolate our country as the red zone. Yeah. Is the Prof. Nasrum already in this room, Dr. Isra? I hope you don't mind to wait for a moment, Doc.
No, not at all.
Dr. Isra? I think she also has a problem with the internet connection.
Can I ask you all, is my background screen, is it backwards?
Sorry, it looks
Sorry?
perfect for me. It looks
Oh,
perfect.
good. Okay, excellent.
Yeah.
Thank you.
But
Yep, it's perfect. Okay. So let me give a call.
Diinstal si Eve ya. Coba magkuhanan. Ikaw sa magkuhan ko na pila naman sa.
2 minutes. Otherwise, we can begin our talk for today.
Fakultas Kedokteran Gigi Universitas Hasanuddin secara resmi didirikan berdasarkan keputusan Rektor Universitas Hasanuddin dan keputusan Menteri Pendidikan sejak tahun 1983. Saat ini, peminatan terhadap Fakultas Kedokteran Gigi Universitas Hasanuddin semakin meningkat dari tahun ke tahun melalui jalur reguler dan internasional, sejalan dengan program World Class University. Hingga saat ini, Fakultas Kedokteran Gigi Universitas Hasanuddin telah menghasilkan ribuan alumni yang telah tersebar di seluruh dunia demi meningkatkan ilmu dan keterampilan, mengabdikan diri kepada masyarakat, mulai dari kota hingga ke pelosok negeri. Program studi kedokteran gigi Universitas Hasanuddin telah terakreditasi A untuk tahap sarjana dan akreditasi B untuk tahap profesi berdasarkan pada keputusan LAM PTKes. Program studi ini ditunjang dengan sarana dan prasarana seperti e-library Fakultas Kedokteran Gigi Universitas Hasanuddin, 33 ruang tutorial, 3 ruang kelas internasional, serta 3 aula. Ruang laboratorium, USC Center, ruang CBT, ruang jurnal dan unit production house, ruang dental education unit, serta bekerja sama dengan Rumah Sakit Gigi dan Mulut Pendidikan dan Rumah Sakit Pendidikan Universitas Hasanuddin. Program studi sarjana kedokteran gigi dan program studi profesi kedokteran gigi memiliki visi sebagai pusat pengembangan ilmu pengetahuan, teknologi, dan riset kedokteran gigi yang bersaing di tingkat nasional dan internasional dalam bidang pendidikan, penelitian, dan pengabdian kepada masyarakat dengan berbasis benua maritim.
Okay, ladies and gentlemen, we have Dr. Masrum here with us. Dr. Janov, I'm sorry for the delay, but we're waiting for our Vice Rector to be here with us. And Prof. Masrum. Okay, do apologize for Prof. Masrum to just let you know that we have this meeting. Hello, Prof.
Yeah, hello. So I'm very sorry. Okay.
It's okay, Prof. It's okay. We begin now, Prof.
Yes.
Yeah, I leave it to you, Dr. Isra.
Okay, thank you, Dr. Erni. Bismillahirrahmanirrahim. The Honorable Rector or Vice Rector of Hasanuddin University, represented by Vice Rector Professor Dr. Muhammad Nasrum Masih, PhD, SPMK. The Honorable the Dean of Faculty of Dentistry, Hasanuddin University. The Honorable the Dean of Faculty of Dental Medicine, Universitas Erlangga. The Honorable, our speaker today, Ivan Stoyanov, DMD, MMSc. Our colleagues, ladies and gentlemen, distinguished participants, good morning and best regards to all of us. Assalamualaikum warahmatullahi wabarakatuh. Today, we would like to warmly welcome you all today on the 11th Virtual International Symposium Series that held by Faculty of Dentistry Hasanuddin University, Makassar, in collaborating with Faculty of Dental Medicine, Universitas Airlangga, Surabaya. Today, in theme Oral Leukoplakia, Recent Knowledge and Understanding. Ladies and gentlemen, as the beginning of this webinar, we would like to invite Vice Rector of Hasanuddin University to deliver a welcome speech and officially opening this event. To Professor Dr. Muhammad Nasrum Masih, PhD, SPMK, please, the time is yours.
Okay, thank you very much, Dr. Israyani. Yeah, thank you very much, Dr. Ernie, and Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everybody. Especially for our speaker, Professor Ivan Stojanov, yeah, from Department of Oral and Maxillofacial Medicine and Diagnostic Science, Case Western Reserve University School of Dental Medicine, Cleveland, Ohio, United States of America. Thank you for giving us a lecture today. Especially, I want to say thanks to the two deans who always make it collaboration in virtual international webinar today with the topic oral leukoplakia for Dean of Faculty of Dentistry from Airlangga University and from Hasanuddin University. Thank you very much for this collaboration, and as a representative of the Universitas Hasanuddin, we want to say thanks for this every series of this collaboration and webinar to add our knowledge and skill, especially related with the dentistry. We really hope that this collaboration always continue, and hopefully that can not only for the webinar, but we hope that all activity related with the proposal, research, collaboration, and publication, and together make it a proposal for getting a grant, international grant. We hope that we can continue for this. As a representative of the Universitas Hasanuddin, Universitas Hasanuddin now is already enter in the list of KS ranking. Now, this 2021, we already entered in the list 100 until 100 to 1,000 until 1,200. It means that we can join in the KS ranking by subject. So it means that any faculty can increase their ability in academic reputation, in employee reputation, and internationalization to become to enter in the KS ranking by subject. That's why we always support all activity related with the academic reputation. Academic reputation means that we can increase our colleague from abroad for the publication, for the research collaboration. So it means that we want to branding our university, branding our subject, especially Faculty of Dentistry, to become internationalization, to become many researchers want to join together with us, and hopefully that can be one of the way to increase our academic reputation. That's why we really hope that any kind of activity like this time, and especially guest lecture in the webinar and any other activity, we hope that always continue in between our university. thank you very much for all the activity and especially for the steering committee and all people who related with the activity. We really thanks for this. And by saying Bismillahirrahmanirrahim, we can start this oral virtual international webinar series with the subject, with the topic is oral leukoplakia. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Prof. Nasrum, for your warmly welcome speech and officially opening this event. Okay, ladies and gentlemen, distinguished participants, before we begin the session, if you have any question, kindly raise hand or please insert in Zoom chat feature below. And I inform you all today, there are 10 bottles of OxyFresh fresh bread for 10 best participants with best question, which gonna choose by our moderator or our organizing committee about this interesting topic. Okay, ladies and gentlemen, we are now enter the main session of this event. And for the session, will be led by our moderator, Hedwin Kadrianto, DDS, Oral Medicine Specialist. A brief introduction of the moderator, born in Jakarta, July 3rd, in 1988. Graduate his dentist degree in 2011 in Universitas Indonesia and oral medicine specialist in 2014 in Universitas Indonesia. He is currently as a specialist clinician in Klinik Utama Rawat Inap Kartika Surabaya from 2019 until now. He has a number of experiences of scientific speaker and several titles of scientific publication about oral disease and oral medicine. To moderator, Dr. Hedwin, the floor is yours.
Thank you, Dr. Istrayani and the academic family of Universitas Hasanuddin for allowing me to moderate this wonderful webinar this morning. And an evening for sure for Dr. Ivan Stoyanov. And I just want to quickly share the CV of Dr. Ivan Stoyanov for our interesting topic today. So hope you can see the CV here. So this is Dr. Ivan Stoyanov, Croatian-born American. And this is his affiliation. The education is oral and maxillofacial pathology residency in Harvard School of Dental Medicine, and then continuing with Master of Medical Science in Oral Biology with Harvard School of Dental Medicine, Boston. And from January until now, until June 2016, Chief Resident of Oral and Maxillofacial Pathology. And now the appointments is Present Assistant Professor in Department of Oral and Maxillofacial Medicine and Diagnostic Sciences, Case Western Reserve University, School of Dental Medicine, Cleveland, Ohio, USA, and currently affiliated with different board, American Board of Oral and Maxillofacial Pathology, and then American Academy of Oral and Maxillofacial Pathology, and also part of editorial board of lots of journals, ad hoc reviewers in many journals, and also lots of publications to leukoplakia, also other related oral medicine and oral maxillofacial pathology. And yeah, so Dr. Ivan Stoyanov, glad to have you with us. Okay. Yeah, so the time is yours, around 1 hour for this very interesting topic about oral leukoplakia, hyperkeratosis, and dysplastic lesions. Please, Dr. Ivan.
Well, hello, everybody, and good morning to you all. It's very nice to be with you. I'd like to say thank you to really all of you, to Dr. Ernie, to Dr. Istrayani, to the Vice Rector, to my colleague, Dr. Hedwin, for sharing that wonderful picture with me when I still had a lot of hair. And really to all of you at Hasanuddin University for being here and for taking some of your time for this topic. I wanted to talk today about a subject that is near and dear to me, that is leukoplakia. Some of us may be more familiar with leukoplakia than with others, but when we think about the most important things about leukoplakia, we think about its risk of becoming cancer. We think about the fact that it is precancerous. So over the course of this talk, we really want to try to define some of these words. What is leukoplakia? What is dysplasia? What is precancer? And if we can understand this disease well, we should have a good idea as to how we should be treating patients who have this disease also. So I do send my greetings from Cleveland, Ohio, in the United States, from the School of Dental Medicine at Case Western Reserve University, and also from the Department of Pathology at University Hospital's Cleveland Medical Center. So our talk is about leukoplakia, but the very first question that I want us to ask is, what is dysplasia? After all, the reason why leukoplakia is an important subject is because leukoplakia has something to do with dysplasia. It has something to do with precancer. It has something to do with squamous cell carcinoma. So let's first think about what is dysplasia. And perhaps a few different thoughts come to mind. One of the most common thoughts in terms of what is dysplasia is that dysplasia is some sort of atypia. Dysplasia is some sort of abnormality. It is some sort of development that shouldn't be there or that shouldn't have happened. That's not a bad thought, but I want us to do a little bit better than that. And I want us to understand dysplasia in a couple of ways. Once we've understood dysplasia, then we'll go back to leukoplakia and start to put things together. The very first thing that I want us to know about the word dysplasia is that it is actually a word with two meanings. Maybe you have some words like that in your language. In the English language, we have a few words like that. We call them homonyms. And so I have here a picture of a mother who's asking her son for glasses. Now the mother is asking for her reading glasses so she can read. The son didn't understand. The son thought that maybe she needed some glasses of water. And so we have the word glasses, the same exact word, spelled the same exact way, and it means two entirely different things. Dysplasia. The first thing I want us to know about dysplasia, before we even get to leukoplakia, is that dysplasia is a homonym. It is a word with two different meanings in two different contexts. And even in dentistry, when we think about our coursework or when we think about the diseases that we learn about, we use the word dysplasia in two separate ways. And so let me give a couple of examples. I have here a picture of an old cartoon movie, but a famous cartoon movie, at least famous in the United States. This is Snow White and the Seven Dwarfs, and maybe this is a movie that is familiar to some of you as well. Here is Snow White, and here are the Seven Dwarfs. They're so short. Now, I do not know what medical condition these dwarfs have. I can only guess. But my guess is that these dwarfs have achondroplasia. Achondroplasia is one of the most common causes of dwarfism. It is a very common skeletal dysplasia. And so we get to our first use of the word dysplasia. Some dysplasias are skeletal. And when we use the word dysplasia in the setting of bone diseases, we are talking about a group of conditions that affect bone development, as well as other tissues and organ systems on occasion. And achondroplasia is one such example. We actually know about many other skeletal dysplasias. And depending upon where you are in your professional development, you may be able to or may not be able to come up with other skeletal dysplasias. And so I want to show pictures of a couple of other skeletal dysplasias. This example on the top is of a 30-year-old lady from about the age of 16 or 18, she started developing swelling on the left side of her face. And this swelling was slowly increasing in size until her present age, and she required a resection of the left side of her mandible for her condition. And she had fibrous dysplasia. So fibrous dysplasia is another skeletal dysplasia. Here on the bottom is a condition that we see fairly frequently in the United States, typically in people of African descent. And so this is something that we encounter frequently. I do not know how frequently you all may encounter this condition in Indonesia, but this lady has a condition called cemento-osseous dysplasia. Cemento-osseous dysplasia. So we have some diseases: fibrous dysplasia, cemento-osseous dysplasia, achondroplasia. Here's another one that maybe some of you learn about in your courses. This is a lady with cleidocranial dysplasia. She is missing her clavicles, and she has many supernumerary teeth. All of these diseases are examples of dysplasias, and many of them even have the word dysplasia in them. But when we use the word dysplasia in this setting, what are we not referring to? We are not referring to any sort of relationship with cancer. So when we're thinking about dysplasias, the very first thing I want us to understand is that there are skeletal dysplasias and there are epithelial dysplasias. If all we think about dysplasia is abnormality or atypia, then we are missing one important point. There are many dysplasias that exist in which the abnormality has nothing to do with cancer whatsoever. And then there are dysplasias that exist in which the abnormality or the atypia has something to do with cancer. And so that is really our question and the first focus of our talk. What exactly is dysplasia in terms of its relationship to cancer? Maybe we think about the term precancer, or maybe we think about the term premalignant. Those are interesting words and correct words, but what do those words actually mean? We don't really use those words in other settings. You do not learn about pre-cavities or pre-gingivitis. So what exactly do we mean when we say precancerous, premalignant? What exactly is an epithelial dysplasia? So here is a patient with a white lesion on the lateral border of the tongue. We could call this a leukoplakia. This is a patient who has a biopsy-proven epithelial dysplasia. So when we use the word dysplasia in this setting, we are meaning something different and something specific as opposed to the other settings. For this particular dysplasia, this patient has some sort of relationship or potential relationship to developing squamous cell carcinoma. So now that I mentioned squamous cell carcinoma, now that I mentioned cancers, now that I mentioned neoplasms, I want us to stop here and make sure that we think correctly about what a neoplasm is, because this will be important when we understand what a dysplasia is. Now and for the rest of the talk, when I use the word dysplasia, I will be referring to epithelial dysplasias. So we should perhaps know that generally speaking, there are two types of neoplasms. There are neoplasms that are benign, like this leiomyoma of the uterus, and there are neoplasms that are malignant, like this cartoon drawing of a leiomyosarcoma. And benign and malignant neoplasms generally have many differences. The most important one being that malignant neoplasms can metastasize. But if we want to understand what dysplasia is correctly, we need to know that this is increasingly an outdated understanding of neoplasia. There are actually three different types of neoplasms. There are benign neoplasms, there are malignant neoplasms, and there are dysplasias. So this is the first point I will try to make. A dysplasia, an epithelial dysplasia, is a type of neoplasm. So what exactly is a neoplasm? A neoplasm is a disorder of cell growth, and this disorder is triggered by a series of genomic alterations, such as mutations in certain important genes. And I have here a cartoon and a diagram of what is called the genomic progression model of a cancer that is fairly well studied, colon cancer. And so the same way maybe you use your GPS on your phone and you know that you need to get from here to here to here to here, and then you get to your final destination. In the same way, cancer biologists understand which mutations need to happen for a cancer to develop. First one mutation, and then another, and then a third one after that. And after 3 or 4 or 5, a cancer can develop or a tumor can develop. And so in order for normal tissue or for a normal cell to become a tumor, it needs to acquire, it needs to develop many properties that it does not normally develop. And so the mutations, for example, these mutations in colon cancer, the mutations that occur, they are very, very helpful for a cell that is becoming cancerous. These mutations give cells, in one form or another, they give them a growth advantage and a survival advantage over the cells around them that are not mutated. So what is a neoplasm? A neoplasm is a disorder of cell growth that is triggered by genomic alterations. That is true for benign neoplasms, that is true for malignant neoplasms, and that is true for dysplasias. In the same way, when you go to a grocery store and you have a list of things that you need to get, and whenever you find something, you scratch it off the list. When normal tissue is becoming neoplastic, when it is becoming a tumor, it is acquiring genetic mutations. So now that we know what a neoplasm is, the first thing I want us to understand is that dysplasias are neoplasms. And when we use the word precancerous, or when we use the word pre-malignant, we are referring to the fact that these neoplasms, dysplasias, they contain some, but they do not yet contain all of the necessary mutations to become cancer. And so on the top right, I have an example of normal hard palate. This purple tissue is epithelium, stratified squamous or multi-layered, and this pink tissue is connective tissue, lamina propria. Now, I might be the only pathologist in the audience, so maybe you will need to take my word for it, but this is an example of a dysplasia. And I hope that even without advanced microscopic training, you will believe me when I tell you that the top half of the epithelium looks different from the bottom half. The top half is normal. The bottom half looks different because there is a tumor. There is a neoplasm that is growing inside of the bottom half of the epithelium. We call this a dysplasia. And if this dysplasia, if this neoplasm acquires the rest of the mutations it needs to, then this neoplasm will stop growing in the epithelium alone, and it will also start to grow very dangerously into the connective tissue, where it can access blood vessels and nerves and metastasize. So dysplasias are neoplasms that contain some, but not all the necessary mutations to become cancer. And so I'm making the case that we have 3 types of neoplasms: benign neoplasms, malignant neoplasms, and dysplasias. Why can't we just call dysplasias benign? After all, if we get rid of this whole thing, then this patient should be just fine. The reason why we cannot call dysplasias benign is because if we look at this benign tumor, this is a lipoma. If you, as a dentist, if you had magic powers and you knew that this was a lipoma, would you need to take the lipoma out? It would be a good idea to take it out. It would be kind to your patient to take it out, but would you need to take it out? Probably not. If your patient didn't want to, you could tell your patient that they have a lipoma and that this lipoma will never become cancerous. It will never become liposarcoma. After all, this is a benign neoplasm. We cannot have the same conversation about a dysplasia. We cannot tell a patient that their dysplasia will always remain a dysplasia. As a matter of fact, the opposite is true. We have to tell our patients that we would like to remove the dysplasia before it becomes cancer. Remember, if we go back a slide, dysplasias are halfway through their grocery list. They have half of the necessary mutations, or 2/3 or 1/3, whatever the number may be, but they do not yet have all of the necessary mutations that allows them to grow everywhere. And so why can't we call them malignant? So here is our epithelial dysplasia. Is it fair to tell this patient that they have a malignancy? No, it's not fair. The same way, or not the same way, but when we have a patient who has squamous cell carcinoma, this is malignant. And so this brings us to the second quality of dysplasias that I want you all to understand. The first is that they are neoplasms. They are neoplasms that contain some, but not all, of the genetic mutations of a cancer. The second quality is a quality we've already started to talk about, but here I want to emphasize it. Dysplasias are, by definition, intraepithelial. They are within the epithelium. Remember, our epithelium, which normally lines the oral cavity, is stratified or multi-layered. That means there is room inside of it for a neoplasm to grow. And so a dysplasia is a neoplasm, and we've learned one important thing about it, genetically, what its relationship is to cancer. And now we're learning about the second important quality. This neoplasm is confined to the epithelium. The basement membrane, which divides the epithelium from the connective tissue, is forming a barrier so that this tumor cannot yet spread into the connective tissue. Only after dysplasia has acquired the rest of the cancer-causing mutations it needs is it able to grow into the connective tissue, and that is when we call it squamous cell carcinoma. So let's refresh. What is dysplasia? Dysplasia is intraepithelial neoplasia. That is the simplest way to think about dysplasia. And this phrase should not be so difficult to understand. In some parts of the body, that is already what we call dysplasia. For example, in the cervix, we call dysplastic lesions cervical intraepithelial neoplasias. At least that's what we do in the United States. So dysplasia is an intraepithelial neoplasm. We've learned what a neoplasm is. We've learned that dysplasias have some, but not all, of the genomic alterations of a malignancy. And for the time being, they are restricted to being within the epithelium. They're not yet growing anywhere else. I want you to be thinking already about what that means from a management standpoint. That should mean that if we are able to remove a patient's dysplasia, we can feel pretty good about the prognosis we are giving them. So carcinogenesis is a multi-step process. Just like when you go to the grocery store, you have a multi-step process. You need to get 3 or 4 things. And so a dysplasia needs to acquire several mutations before it can become carcinoma. And when I say become carcinoma, I mean that this neoplasm now has the ability to grow in places where it really should not be growing, within the connective tissue. So with that in mind, how should we be treating dysplasias? What would you do if you had a dysplasia in your mouth? If you knew that you had a neoplasm in your mouth that might become cancer, If you had that in your mouth, what would you do? I know what I would do if I had it in my mouth. I would ask for it to be removed. And if it was successfully removed in my mouth, I would feel very good because I know that that dysplasia that was just removed, it was intraepithelial. It was only within the epithelium, which means that I know for certain that that dysplasia had not yet metastasized. So whenever we are able to remove a dysplasia for our patient, we are usually doing a good thing. At least that is my opinion. But how do you think dysplasia should be treated? I think some helpful information to answer this question is to learn about some percentages. These numbers that I have here in red, these are the percentages that are generally accepted for the risk of malignant transformation of dysplasia. Around 6% for mild dysplasias and 22 to 28% for moderate and severe dysplasias. I put these numbers in parentheses just to tell you all what exactly do I mean as a pathologist when I call a dysplasia mild or moderate or severe. In most cases, what I am doing is giving an opinion as to how much of the epithelium is involved by the tumor, by the neoplasm, by the dysplasia that is growing within it. Is it only a third or half to 2/3, or is it almost the entire thickness? So that's where the terms mild, moderate, or severe come from. But now we get back to our percentages, 6% and higher. What would you do if you had a mild dysplasia in your mouth and it was small enough to be removed? If it was in my mouth, I would probably have it removed. And this is usually what we do in other parts of the body as well. We usually prophylactically remove premalignancies in order to reduce the incidence of cancers. And so I have here a cartoon of a colonoscopy. And perhaps we've learned about colonoscopies elsewhere in our coursework. But when a colonoscopy is performed and a polyp is identified, the polyp is always removed. Why is the polyp removed? The polyp is removed because it might become cancerous. Now, it might be interesting to know that the malignant transformation rate of any single polyp is about 5%. But there is not a doctor in the world who will decide to monitor or to follow a polyp. It's easy to remove, so let's go ahead and remove it. And we do the same thing with precancerous lesions on the skin as well, called actinic keratosis in most cases. And look at how small is the annual malignant transformation rate. These are very small numbers that I'm giving examples of, and yet doctors who work in these parts of the body, they think the best thing they can do for their patients is to remove these premalignancies. And so my opinion is that we should have the same approach for our patients as well. Now, there will always be exceptions. I have one leukoplakia, one epithelial dysplasia here on the top, and another one on the bottom. This one is easy to remove. This one is not so easy to remove. And maybe for a patient like this, we might not even be able to remove it. So there are always challenging situations. But my goal here, just for this point of the talk, is to say that whenever it's possible, we should be trying to remove epithelial dysplasias. After all, if we look at this bottom one, it's easy to think that once upon a time, maybe 5 or 10 years ago, this dysplasia was only this small. And wouldn't it have been nice if somebody had removed it then? Now the situation is a little bit more complicated. So we've thought a little bit about what dysplasias are, and we now understand that dysplasias are intraepithelial neoplasms, and they have some, but not yet all, of the mutations of what they want to become, which is invasive carcinoma, carcinoma that is invading into the connective tissue. So now here's a question for you all, and with this question, we'll start to think a little bit about leukoplakia. If dysplasias are intraepithelial, why on earth are they white? Hopefully by this point in the talk, we understand that they are intraepithelial, right? And you need to perform a biopsy, and the pathologist then looks at the epithelium, and either they see the dysplasia or they don't. If they are intraepithelial, then where does the white color come from? Well, the white color comes from the surface keratin. And this is something that is very, very helpful for us as dentists. Dysplasias, epithelial dysplasias in the mouth, are by definition what we call keratinizing. Epithelial dysplasias in the mouth are always keratinizing, which means that these dysplasias always produce excessive amounts of surface keratin. That is a very nice thing. They produce so much keratin that clinically you can identify a white lesion. Now, there are some parts of the body in which epithelial dysplasias are non-keratinizing. Now, in those parts of the body, it is much more difficult to identify dysplasias. I'll just say for now that we can be grateful that in the mouth, epithelial dysplasias are keratinizing. Because epithelial dysplasias are keratinizing, they frequently present as a white lesion. And the reason why, as dentists, we are trained to be very careful when we identify white lesions is for this reason, because epithelial dysplasias are usually white. So how are we doing so far? We've learned about what is dysplasia, and now we've understood why are dysplasias white in the mouth. So now let's get to leukoplakia, having gotten a firm and good understanding of what dysplasia is. So leukoplakia, according to the World Health Organization, is a white plaque of questionable risk, having excluded other known diseases or disorders that carry no increased risk for cancer. Now, in my opinion, this is not a very good definition. Half of the definition, maybe 2/3 of it, doesn't even say anything. What is leukoplakia? It's not something else. Well, of course, it's not something else. So really, when we look at this definition, the only definition that's helpful is a white plaque of questionable risk. Of course, a leukoplakia is not something else. A leukoplakia is a leukoplakia. But what is a leukoplakia? According to the World Health Organization, a leukoplakia is a white plaque of questionable risk. But let us see if we can understand an even better definition of what a leukoplakia is. I want us to use the word leukoplakia, at least for this talk, in a very, very specific way. Leukoplakia is simply the clinical appearance of keratinizing epithelial dysplasia. If you are looking at your patient's epithelial dysplasia, you do not know that it's dysplastic, a biopsy is necessary, and then the pathologist needs to identify the dysplasia. But you are looking at the patient's leukoplakia. Leukoplakia is the clinical appearance of keratinizing epithelial dysplasia. So we're going to use this term now. We are not going to use the word leukoplakia to refer to anything that is white in the mouth. We'll get there in just a minute. But let's think about what leukoplakias tend to look like. Leukoplakias present as white plaques, and that should come as no surprise. We just learned that dysplasias are keratinizing. They produce surface hyperkeratosis, and then we see white lesions. Leukoplakias can be homogeneously thin if there is only a little bit of surface keratosis. They can be thick if there is more keratosis. And sometimes leukoplakias can have red components, and we use the word erythroleukoplakia. There is an association between how long a leukoplakia has been present in a patient's mouth and how much more aggressive it might look. By more aggressive, I mean more hyperkeratotic or possibly even erythematous. And then there's a final association between an increased risk of progression to squamous cell carcinoma. I hope that by this point in the talk, this association makes perfect sense because we know what a dysplasia is. A dysplasia is a neoplasm that has some, but not all of the mutations of squamous cell carcinoma. And if we let a dysplasia sit in a patient's mouth, there's a chance that that dysplasia will acquire more and more mutations. And the more and more mutations it acquires, the closer it is to becoming squamous cell carcinoma. So we're thinking about leukoplakia and dysplasia as basically the same word. Dysplasia is the disease when a pathologist like me looks at it under the microscope, and leukoplakia is the part of the disease that you as the clinician look at when you see a white lesion. So that is how I want us to think about leukoplakias and dysplasias for now. Now let's look at a couple of clinical images of leukoplakias. After all, as dentists and dental specialists, your job is to identify a leukoplakia whenever your patient has one, because you might be able to do something very good for that patient. You might be able to remove it. You might be able to refer the patient to an oral surgeon or an oral medicine specialist to remove it. So what exactly should we be looking for? These top two images are examples of homogeneously thin leukoplakias. The hyperkeratosis is so thin that you almost do not see it. Only here at the top can you see a little bit of the border. And once your eyes start to go around the border, you can recognize that this is actually a very, very large leukoplakia. And the same is going on here. Look at how large this leukoplakia is. It's almost scary. And we have two more leukoplakias here. These are a little bit easier to see. There is a little bit more keratosis than here. Again, we have a few more examples of leukoplakias, and I want you to start to notice one of the very helpful clinical signs. Leukoplakias tend to have very sharp and well-demarcated borders. What do I mean by sharp borders? If I asked you to put a circle around this leukoplakia, you would probably all draw the circle in the exact same place. The borders of the lesions are very clear. And that is the case for all of these leukoplakias. Sometimes the borders are a little bit irregular, but they're always very clear, very sharply distinguished. Here we have a few more leukoplakias. We can begin to see a little bit of fissuring. Here is a very, very interesting leukoplakia. Our eyes maybe are drawn to this area first, but if we look closely, we can see that there is a leukoplakia that is extensively involving most of the ventral surface of the tongue. Again, I hope that this clinical appearance makes sense. What is leukoplakia? Leukoplakia is the clinical appearance of keratinizing epithelial dysplasia. And what are dysplasias? Dysplasias are these neoplasms that are continuously trying to acquire more and more mutations. So here, within this field of leukoplakia, is a smaller focus that has progressed. Maybe it has progressed to a higher grade of dysplasia. Maybe it has progressed to squamous cell carcinoma. So this, of course, is the most important area to biopsy. But if we're trying to remove the leukoplakia, we need to remove the entire lesion, which might be difficult. Here are a few more examples of leukoplakias. What do these all have in common? Sharply demarcated borders. Again, we can see fissuring in advanced cases. And here are some erythroleukoplakias. The borders are not so well demarcated here. We can't really tell where the disease ends and where normal tongue begins. It all just looks bad. So we start to lose the sharp borders with more advanced disease. But I would make the case that what you lose with the advanced borders, you gain as a clinician just by recognizing that this looks very bad. It should be fairly easy to recognize that this is not supposed to be here. So what do we think about the clinical appearance of leukoplakias? Most helpfully, they are well demarcated. Other white lesions, which we will talk about in a minute, other white lesions are generally not so well demarcated. Here is a man who is chewing on his cheek, and it's kind of hard to tell all around where the lesion begins and where it ends. Like, does it kind of go here? Does it go down here? It's hard to say. This man's cheek looks a lot more like the welcome mat that might be in front of your door. That mat does not have two pretty footprints. It just looks kind of used up and worn out all over the place. So we've learned a little bit about what leukoplakias look like. What else do we know about leukoplakias? Well, the risk factor for leukoplakia development is the same as the risk factor for squamous cell carcinoma development. The risk factors are tobacco and alcohol use mostly. And there are other risk factors as well, immunosuppression, or a personal or a family history of cancer, areca or betel quid use, HPV, which causes a large fraction of oropharyngeal cancers, also causes maybe 1, 2, 3% of oral cancers. We see leukoplakias in middle-aged and elderly men most frequently. This is, after all, the part of the population that uses tobacco and alcohol most often. And leukoplakia we most frequently see on the lateral and ventral tongue, as well as the floor of mouth. Some people say that is because the non-keratinized mucosa is more susceptible than keratinized mucosa, but I think it is because of saliva. Saliva, which is full of carcinogens from tobacco and alcohol, because of gravity, it rests in the floor of the mouth. And so that saliva is constantly touching the floor of mouth, and the tongue is on top of it, the ventral tongue. So these mucosal surfaces are always in contact with carcinogen-rich saliva. So we think about leukoplakia, or we define leukoplakia as epithelial dysplasia. And if we do that, if we define leukoplakia specifically as epithelial dysplasia, it allows us to understand leukoplakia research that has been published a little bit better. Because if we think of leukoplakia as epithelial dysplasia, then we can understand that leukoplakia truly is a pre-malignancy or a pre-cancer. And we know what these words mean now that we know what dysplasia is. What is a pre-cancer? A pre-cancer is a dysplasia. It's a neoplasm that has acquired some, but not yet all, of the necessary mutations to become cancerous. Once it has acquired all of the remaining mutations, it is no longer pre-cancer, it is simply cancer. So what is the rate of malignant transformation of leukoplakia? The most helpful percentage is 1 to 3% per year. So annually, 1 to 3% of leukoplakias acquire all of the remaining mutations they need to for the dysplasia, the intraepithelial neoplasm, to now start growing elsewhere, to grow like an invasive carcinoma. So we have one percentage that makes sense, 1 to 3%. That's a helpful percentage. That's something that's good to know. You can tell your patients. And then we have some percentages that make no sense. It is widely cited that the overall malignant transformation rate of leukoplakia to squamous cell carcinoma is somewhere between 0 and 34%. In my opinion, that number makes no sense. How can you possibly have a range that is that wide? Are we as researchers, are we that bad at understanding leukoplakias? Well, I don't think so, but it's possible that there have been some mistakes that have been made in the leukoplakia research. And maybe think about 1 or 2 reasons why this might have happened, 0 to 34%. How can we be so far away from knowing what the truth actually is? Well, in my opinion, there are 2 reasons why this has happened. The first reason is that all studies carry some sort of limitation in them. The limitation is the follow-up period. If I have a study that has a 1-year follow-up period, I'm going to have a very low malignant transformation rate. If I have a study with a 10-year follow-up period, I'm going to have a much higher malignant transformation rate. But even my study with a 10-year follow-up period is probably going to be too low because we've thought about what a dysplasia is already. And dysplasias have a fairly high chance of becoming cancer, 5 or 6% at least. We know that everywhere else in the body, if somebody has something that has a 5% chance of becoming cancer and it can be removed, the doctor removes it. And so with that in mind, it's very difficult to justify a study in which a patient has a leukoplakia, they have an epithelial dysplasia, and we follow the patient until they develop cancer. We're really not behaving ethically if we do that. So all of our studies will in some form or fashion underestimate the rate of malignant transformation unless we follow every single patient until they develop cancer or die of another disease. But this is only one reason why the percentage is so wide. There is a second reason that is probably more important. The second reason is that dysplasias are not the only things in the mouth that are hyperkeratotic. They're not the only things in the mouth that are white. They're actually rather uncommon. And those of you who see patients know that. Here is a white lesion that is present on the alveolar ridge, the maxillary alveolar ridge. Why does this patient have a white lesion here? Does anybody have any opinions? If this were your patient, would you biopsy this white lesion? Or would you just tell the patient, you have a white lesion because your mandibular molars are always hitting the gingiva? Maybe some of you would do a biopsy to be on the safe side. Maybe many of you would not. If this patient has been smoking for 50 years, would you do a biopsy? You probably would do a biopsy just to be safe, even though you do not think that this is a dysplasia. So you see part of the problem. We biopsy, and we are supposed to biopsy white lesions to be safe because we want the best for our patient and we don't want to take any chances with the diagnosis. Now, if you decide to biopsy this white lesion, just because you call it a leukoplakia doesn't mean that it's a leukoplakia. Really, what you are saying is that it's a white lesion and you can't wait to find out what the pathologist says it is. So we have a situation in which the vast majority of white lesions are not epithelial dysplasias. And I would even say that the vast majority of white lesions that are biopsied are not epithelial dysplasias. We just biopsy them because we want to be careful. This white lesion is an example of a BARC, benign alveolar ridge keratosis. It is essentially a callus that is developing along the retromolar pad or the alveolar ridge because of trauma from food or from opposing teeth. It generally has poorly demarcated diffuse borders, but it's not always so easy to diagnose. If you were looking at this lesion and your patient told you that they have been smoking for the last 50 years, you might say, well, I don't think this is a dysplasia, but I really can't be positive. We need to biopsy this. And so we end up biopsying, for many of our patients, we end up biopsying BARCs. Fortunately, BARCs look a very certain way under the microscope, and so a pathologist should be able to tell you that the white lesion you have biopsied is a BARC. Here's a second example, and I'll ask the same question here. Would you biopsy this white lesion? would you biopsy this white lesion if your patient was smoking for the last 50 years? You probably would, even though you felt pretty confident that this is not a dysplasia, that this is not a leukoplakia. You would probably biopsy this, even though you're fairly confident the patient is just chewing on their cheeks, because you want to be safe. This is cheek chewing, of course, and cheek chewing looks a certain way under the microscope as well. And so a pathologist can recognize it and say chronic frictional factitial keratosis. And we frequently use the Latin words as well, morsicatio. At least in America, we frequently use the Latin words, morsicatio. This simply comes from the word morsus, which is Latin for bite. And so we have these white lesions. We have these hyperkeratoses that have nothing to do with dysplasia whatsoever. These are not premalignant. They are not precancerous. If this patient decides to spend the rest of his life chewing on his cheek, the fact that he chews on his cheek will not make it precancerous. We have these white lesions here that have nothing to do with cancer. However, in many instances, it is appropriate and correct to biopsy them. And so what happens in regular clinical practice, we do exactly that. We biopsy white lesions to be safe. And so a lot of white lesions get biopsied that have nothing to do with cancer. And so what happens when we include those in our leukoplakia studies? If we include in our leukoplakia research, if we include biopsies of all of these white lesions that have nothing to do with cancer, except for the fact that it's a good idea to biopsy them just to be safe, are we going to be artificially elevating or artificially decreasing the data, the statistics? We will be artificially decreasing it. We will make the rate of malignant transformation lower than what it actually is. Now, nobody should feel guilty about biopsying these lesions. Again, we put our patients first. After all, when you go to the airport, the people who work in security, they do not apologize for making you go through screening. They are doing the best they can to make sure everyone is safe. And so the same way for you, you do the best you can. And if you need to, you take a biopsy. So why is the percentage so wide? We've talked about the variability in follow-up periods. And we've even thought about the fact that it is probably unethical to take 100 patients with dysplasia and just wait on all of the patients to see how long it takes them to become cancer after 5, 10 years, and so on and so forth. And then we have a second reason. All historical leukoplakias, to one extent or another, are contaminated by the inclusion of hyperkeratoses that are reactive or frictional, that have nothing to do with cancer. And so let me draw attention to one study here, and this is a study from 2014. It came out of a group in Boston, and it talks a little bit about what I just tried to explain here. This group, this pathology group, they took 1,251 hyperkeratoses that were biopsied over a period of, I think, 2 or 3 years. And they found that of all of these white lesions, many of which the clinician called leukoplakia, just to call it leukoplakia, 75% were reactive. And so that maybe agrees with your experience if you see patients clinically. Most of the time when you see a white lesion, the patient is traumatizing the area. Less often is it truly a dysplasia. But this paper now has a second piece of information that I want us to focus on. The second piece of information is that after all of these reactive hyperkeratoses were removed from the study, only 40% show dysplasia or carcinoma. Only 40. Now, if you're following the talk so far, this should be a little bit confusing. It should be 100%, right? We've gotten rid of all of the other stuff, and you have said that dysplasia and leukoplakia are the same thing, but only 40% show dysplasia. So what exactly is going on here? Well, for starters, what do we mean by unknown significance? I'm referring to the fact that as a pathologist, if you biopsy or if somebody biopsies morsicaceae, cheek chewing, I can recognize that. And so I know as a pathologist what the significance of this hyperkeratosis is. And in the pathology report, I can say chronic frictional factitial keratosis. For this hyperkeratosis, when I evaluate it, I can recognize the significance. It's not unknown to me. This is what a bark looks like. And so in the pathology report, I can say benign alveolar ridge keratosis. But what about this case? So here's hyperkeratosis, but as a pathologist, I can't tell the significance. It doesn't look like anything I showed you before, and it doesn't look like a dysplasia either. And look, I'll even compare it with dysplasias. So here's a mild dysplasia. You can see a little bit of a neoplasm growing here, moderate a little bit more, severe, like a whole lot of neoplasm growing. But here, there's nothing here. This is just the normal basal cells that are turning over. There's nothing here. What is the significance of this hyperkeratosis? These are the kinds of specimens that are present in 60% of leukoplakia biopsies. Well, let me show you the clinical. Here is the histology, and this biopsy came from this patient. This sure looks like a leukoplakia, doesn't it? Well demarcated borders involving the ventral tongue, but none of this dysplasia on biopsy. So what on earth is going on? Here's another case. Here is keratosis. There's nothing diagnostic here, no dysplasia, nothing that could be diagnosed as any condition I've shown you so far. But here is, and again, here's our comparison. So here's mild dysplasia, moderate, severe, nothing. No one can find any dysplasia here. This epithelium looks very, very normal. Well, this biopsy came from this leukoplakia. So what are we supposed to do with this leukoplakia? How are we supposed to understand leukoplakias if we're saying that leukoplakias and dysplasias are the same thing? These are important questions. So here is an epithelial dysplasia that I have shown you all a few times. 10 years ago, this dysplasia was biopsied, this leukoplakia was biopsied, and what was the diagnosis? Hyperkeratosis. So there is something that is important. There is something that is tricky. There is something that is confusing about these hyperkeratoses. After all, with this patient, if we could go back in time 10 years, and if we could remove the leukoplakia when all it showed was hyperkeratosis, we would have done that, because now we have a much larger problem on our hands. Here's another example. So this image on the top left was biopsied, this right tongue lesion, and it showed hyperkeratosis. And 1 year later, it showed squamous cell carcinoma. So something is going on with these hyperkeratotic lesions, and we need to understand them so that we can understand leukoplakia as well. And I want to show you all one more paper. This is a paper that I wrote with a colleague in Boston. And what we did is we took a look at all of the leukoplakia papers that have been published in the last 30 years, acknowledging that there are many limitations in them. But what we did is we looked at all of the leukoplakia papers that recorded malignant transformation rates. And we found that these leukoplakia papers had malignant transformation rates of 5% of the leukoplakias with no dysplasia. The leukoplakias that had only hyperkeratosis that was not reactive. It wasn't cheek chewing, it wasn't a bark lesion on the retromolar pad. It was a keratosis of unknown significance. It was a hyperkeratotic lesion that as a pathologist we can only say was not reactive, but we're not really sure if it's dysplastic. These leukoplakias have a malignant transformation rate of 5%. And as a matter of fact, of all of the squamous cell carcinomas that have been reported in the leukoplakia cohorts over the last 20, 30 years, almost 30 of them arose from these types of hyperkeratosis. So as pathologists and as clinicians, we're missing something. We need to be able to recognize whatever these are so that we can do something for the patients. Maybe remove them, or at the very least know that we need to follow them. This is extremely important to understand because this 5% number is basically the same as the 6% number of mild epithelial dysplasia. This 5% number is the same number that we have for colon polyps that people remove. So we need to be paying close attention to these lesions and understanding them better. In my opinion, the best thing that we should be doing is to be recognizing these as another example of mild dysplasia. And actually, as pathologists, we need to be changing our criteria of what we call dysplasia. If we do so, we will be able to issue better reports, and we truly will be able to understand leukoplakias as the clinical presentation of keratinizing dysplasia. So here is our cartoon, and really we've been thinking about how leukoplakia is the part of the disease that you see. You see the hyperkeratosis on the outside, and I, as a pathologist, I see the dysplasia on the inside. But really what we are increasingly learning is that leukoplakias, genetically mutated epithelium, it first manifests with atypical hyperkeratosis, and only afterwards does it manifest with a generous amount of intraepithelial neoplasia that a pathologist can truly recognize. So what does that mean? That means that if we as clinicians are really doing a good job of biopsying and identifying leukoplakias, many of these will be biopsied in this particular phase, where the most notable finding is hyperkeratosis. And we need to learn how to recognize these hyperkeratotic lesions as premalignant. Another paper that comes out of the Boston group, this is from 2 years ago, this shows that these hyperkeratotic lesions, which are called KUSs, keratoses of unknown significance in some papers, and HKNRs, hyperkeratosis non-reactive in others. The letters themselves aren't important, but the concept is. These leukoplakias that don't yet really show a lot of dysplasia, they show a similar pattern of genetic mutation to epithelial dysplasia. So what does that mean? Well, it means what the malignant transformation rates suggest. The malignant transformation rates suggest that these hyperkeratoses and mild dysplasias are basically the same thing at the end of the day. And genetically, we're learning that they're very similar as well. And so perhaps the best thing that we can be doing as pathologists and also clinicians is simply learning to recognize these as mild dysplasias, or at the very least, to recognize hyperkeratosis that is premalignant as opposed to hyperkeratosis that is frictional or reactive. So again, I'm the only pathologist here, but there are some hyperkeratotic lesions like morsicaceae or bark that have a 0% chance of becoming cancerous. Even if we call them leukoplakia, they don't have any chance of becoming cancerous. We're just using the word leukoplakia incorrectly. But there are some hyperkeratotic lesions that do have a chance of becoming cancerous. They're very similar biologically and in other ways to mild dysplasia. And so this is what we need to be doing. We need to be recognizing why our lesions are hyperkeratotic. Are they hyperkeratotic because they're an early dysplasia, or are they hyperkeratotic because of a frictional process? So we'll end here. And in conclusion, I want us to think about what is dysplasia, intraepithelial neoplasia, right? Containing some but not all the mutations of carcinoma. And what is leukoplakia? I really do want us to think that leukoplakia is the clinical appearance of dysplasia. And probably what we need to be doing is recognizing even these early hyperkeratotic lesions as actually being an example of a very mild dysplasia. And if we think about it that way, it becomes much simpler to think about what a leukoplakia is. And also, from a clinical standpoint, hyperkeratosis is not a diagnosis. All three of these lesions are hyperkeratotic. In order for you to manage your patient correctly, you don't need to know that it's hyperkeratotic. That's not good enough. You need to know why it is hyperkeratotic. And when you've answered the why question, then you can appropriately manage the patient. And that's true for pathologists as well. If a pathologist tells you hyperkeratosis on a pathology report, they haven't told you anything that you don't already know. You know that a lesion was hyperkeratotic when you biopsied it. So what's critical is that we can recognize these white lesions and manage the patients appropriately. So I'll stop here. I will just leave you all with a picture of Cleveland. This is Cleveland in the wintertime. Right now it is summer in Cleveland and there is no snow, but there is plenty of snow here in Cleveland in the wintertime. Thank you all once again for your time and for your attention, and may God bless you. I'll be happy to take any questions in whatever form we want to have the question and answer session.
Wow. Thank you so much, Dr. Ivan Stoyanov, for really great presentation. We know that now we have to be very, very careful with hyperkeratosis that is non-reactive, because it is actually already a form of very mild dysplasia, and that we have to be very careful and possibly remove that. So we have already lots of questions here, and we will jump into the question and answer sessions now. And I will start with a question from Dr. Chandra here. Is it possible that the leukoplakia, even like any kind of hyperkeratosis, non-reactive, reappear again or even get worsened after we remove it?
So is it possible for leukoplakia to get worse? Was that the question?
For example, if you remove the leukoplakia and then it reappear again, recurrence.
That can certainly happen. And an individual who has a leukoplakia, let's say the leukoplakia was successfully removed, that patient still needs to be followed for the rest of their life. Because they have a leukoplakia, maybe they have a leukoplakia because they are a smoker. Well, that leukoplakia might have been removed and they might have even stopped smoking, but there still is a substantial risk and a substantial amount of damage to their mouth. In the same way, if you have a garden and you can pull out all of the weeds of your garden, it's possible that a couple of weeks or a couple of months later, some more weeds will grow up as well. And individuals who have leukoplakia, either because of the risk factors, their personal risk factors, or maybe because of some genetic predisposition that is native to them, they are at risk of developing multiple leukoplakias. That's a good question.
Right. I just want to share that for all participants, if you want to ask directly, if you want to raise your hand or you want to unmute your microphone, please feel free to do that, and we will give you the chance to speak. Yeah, but if I don't see any raised hand, then I will just continue the questions on the chat box. So the next from Wahyuni here, in your experience, have you ever encountered two different spots of clinical white lesion in the same patient, which demonstrate different degree of dysplastic feature? Okay, have you encountered two different spots of clinical white lesion in the same patient?
Absolutely, absolutely. And that happens rather frequently. That question is actually somewhat related to the first question. And the term that is used, the concept that is used to explain that is one that is known as field cancerization. So an individual who maybe abuses tobacco or alcohol their oral mucosa has undergone field cancerization. The same way if you sit in the sun, you get sunburnt. You have been sort of cancerized. Now, some parts of your skin get more sun than others, and so a precancerous lesion might be more likely to develop on your forehead than on your chest because you wear clothes. And even if precancerous lesions develop in multiple areas, one precancerous lesion may show more advanced dysplasia than another, simply because of when the mutations occurred. One of the things to understand about the mutations is that they occur randomly. There's nobody that's driving the bus. This is just a process that is occurring randomly. And sometimes mutations occur more quickly in one location than in another, just because. And so I'm pointing to my skin, but the same is true in the mouth as well for someone who maybe smokes or who has an underlying genetic predisposition. And if you go back to the lecture, I didn't highlight this, but some of the leukoplakia pictures that I showed, if you look closely, there's one leukoplakia and then there's a couple of smaller ones next to it.
Yeah.
And so that is an example of field cancerization.
Thank you so much, field cancerization. All right, so the next one from Dr. Rini Kartini Kadir is dysplasia severity in terms of the area, the size of the area can be an indicator for cancerous transformation.
So is the size of the dysplasia? I think it is the case. You know, when it comes to the malignant transformation of leukoplakias, the most important predictor is the presence of dysplasia. And one of the important secondary predictors is the size of the leukoplakia. And again, if we start to think about leukoplakia and dysplasia as basically being the same disease, then it makes sense. The larger the leukoplakia, the larger the dysplasia. And yes, I think that's absolutely correct.
Yeah. All right. One dentist from a province near East Timor, it's around West Timor, something like that. She said lots of leukoplakia happening because of the areca nut or betel quid chewing. Can we categorize that as oral dysplasia? And apart from biopsy or excisional biopsy, can we do another kind of therapy for that? That's the question.
That's a great question, and I need to be honest with answering that question and say that I probably have the least experience in this room of areca nut and betel quid and submucous fibrosis, because that is not a disease that actually we see very commonly in the United States. The fibrosis that occurs, the fibrosis itself is not actually precancerous. And I think that there are different approaches to addressing the fibrosis in terms of splints and maybe administering steroids intralesionally. But arecaline, that's the substance within the areca nut that is carcinogenic. In the same way we want someone to stop smoking, we want someone to stop using areca nut for that reason. The best thing to do for patients with submucous fibrosis is really the same thing that we do for our patients with lichen planus. We understand that the submucous fibrosis, the lichen planus, those conditions themselves aren't pre-malignant, but they are predisposing. And so these are individuals who are at a higher risk of developing leukoplakia. I am not aware of any approach that is successful in reducing the incidence of leukoplakia in these patients, but that could simply be because I do not know very much about that condition from my personal experience.
Thank you so much. Yeah. Just of course we have to educate about the areca nut risk for cancer and so on, and of course follow up. Yeah. So and you have mentioned some therapy also. And okay, the next one is from Ananda Nurul Fadila. is the degree of clinical keratinization is associated with dysplastic level?
That's a good question. To probably answer it most simply, the answer would be no. But I have to say that as a clinician, you know, if you see a leukoplakia and maybe that leukoplakia is 2 centimeters in size, and some portions of the leukoplakia are really prominently hyperkeratotic and some aren't, as a clinician, you would be making the right decision to biopsy the area that is most hyperkeratotic. Not because there is a perfect, beautiful rule that says every time you will do it correctly, but generally the opinion is what you are asking. The general opinion is that yes, the more hyperkeratotic, the more erythematous a lesion is, the higher the grade of dysplasia. But maybe you can study that and improve it.
Yeah. All right. The next from Dedi Ariwansa. Thank you so much for the lecture. What's the treatment for cheek biting? Should we do immunohistopathology or excision? Yeah, or immunohistochemistry, H&E staining? Yeah.
Okay. So what is the treatment for a white lesion from cheek biting? No treatment is necessary whatsoever. The patient can continue biting their cheek for the rest of their lives if they want to, and if that makes them happy, that's okay with you. The most important thing is to correctly diagnose the white lesion. Because a person who is chewing on their cheek, that white lesion will persist. They most likely will not stop their habit. A patient who has a dysplasia, that white lesion will persist. That will not go away on its own. So it's very important to have a correct diagnosis. I do not think that a diagnosis, if a biopsy is necessary, sometimes it's not. Sometimes you can look at a patient and know they're chewing their cheek and you can just tell them to take a deep breath and that everything will be okay. But sometimes if you need to take a biopsy, that's fine. I do not think there is any need for an excision because there's nothing to excise of any risk. I mean, if the patient maybe is like a supermodel and they want their cheek to look nice and pink, well, maybe that's a different situation there. But for the rest of us, it can really stay. And if you know you have the correct diagnosis, you feel quite comfortable monitoring that patient's white lesion. From a pathologic standpoint, the diagnosis can be made simply on the basis of the visual characteristics. There aren't any immunohistochemical stains that I'm aware of or that I use on a regular basis to discriminate frictional keratoses from dysplasias.
Thanks. Yeah, the next one is how to manage patients with leukoplakia but have comorbidities.
So that's a great question, and that is for you all who treat patients, the dentist, the oral medicine specialist, the oral surgery specialists. How do we manage patients who have comorbidities? In my opinion, I think that we need to know what the gold standard is. And for patients in whom we cannot accomplish the gold standard, we need to educate them and we need to do everything that we can to try to get as close to the gold standard as possible. In my opinion, the gold standard is to remove a leukoplakia in its entirety. And patients may have comorbidities, or a leukoplakia may be so large by the time it is correctly diagnosed that it's not possible to conservatively remove it. Management for these patients is complex. They probably need to be seen on close follow-up every 3 to 6 months. And going back to a couple of questions ago, if there's any change in the size or if a leukoplakia becomes more hyperkeratotic or more erythematous, maybe at the very least we can remove those areas. And in a sense, we can go back to our garden analogy. Maybe we're not able to keep all of the weeds out of the garden, but we can at least get rid of those weeds that are around the tomatoes and that are around the corn. and try to keep things safe for as long as possible. The reason why I'm an advocate of excising dysplasias is because there's a systematic review from about 10 or 12 years ago that shows that excision of epithelial dysplasia reduces the risk of malignant transformation threefold, 3 times. And so even for a patient in whom we might not be able to successfully remove a dysplasia in its entirety, if that patient is 65 years old, and if we can excise a part of a leukoplakia 2 or 3 times, and if we can keep that leukoplakia from becoming cancer for an extra 5 or 10 years, those are valuable 5 or 10 years for the patient. And so I still think that targeted intervention is of some use. There are probably some all sorts of investigational approaches in terms of immunotherapy. Those might become available in a decade or 2, but as of now, surgery is really the approach that I am most familiar with and that has the most proven results.
Thank you so much. Very interesting. Yeah, we have a very interesting questions and discussion so far. The next from Dr. Buahna Lumbangaul. Okay, I have to read this first in Indonesia. Okay, the presentation for leukoplakia malignant transformation is 1 to 3%. So is we obligated to excise the leukoplakia with that presentation? I think it's answered already here, especially for broad or large size or diffuse leukoplakia. And is it okay for some cases to just let the lesion like that?
Yeah, there's 2 ways to answer that question, and there's 2 sides of that question, in my opinion. The first side is that you are correct. If a leukoplakia is too large, you are now in a very difficult situation. There's a second side, and I come to that side as a pathologist. I do not excise leukoplakias. I do not see patients clinically. But understanding what a leukoplakia is and what a dysplasia is, when I see a leukoplakia that is 5 or 6 centimeters in size, I am pretty sure that 5 or 10 years before that, the leukoplakia was only 1 centimeter in size. And so I agree with you that there's nothing that we can do for these patients. Maybe not nothing, but there's not very much we can do for these patients who have a 5 centimeter size leukoplakia. But really, as a profession and as specialists, we need to be answering the question, what can we do differently to identify these leukoplakias when they are 1 or 2 centimeters in size? And that's really where we need to understand best what is dysplasia, what is leukoplakia. But it's a good question.
Yeah, thank you so much. The next is from Dr. Masla Siregar. If we treat leukoplakia as early as possible, is there a chance of recurrence in similar or different locations? And whether the possibility of turning to malignant is lower or higher? How long is leukoplakia treatment successful if there is no recurrence?
Yeah, so you all are asking all of the right questions, you know, and we start to return to a couple of themes. And so we talked about this process of field cancerization, and we thought about people who are in the sun. You know, someone like me, I'm very light-skinned, you know, and someone who is maybe 60 or 70 years old and they have been in the sun their whole life and they develop skin cancer. If that skin cancer is removed, well, it's great that that skin cancer has been removed, but all of the rest of their skin still has 40, 50, 60 years of too much sun exposure. And so it's possible a lesion that has been small all of a sudden develops. The same way in the mouth. You know, a patient who develops a leukoplakia, there's usually a reason why they develop a leukoplakia. And even if that leukoplakia has been excised, there still is the possibility of it developing somewhere else. And what is the possibility of it becoming malignant faster or slower? If I'm understanding the question, that's the reason why we excise. We don't excise because we can guarantee every single patient that it will cure their disease forever. But we're very confident that at the very least, by excising a dysplasia, we're interrupting the process. We're pulling some of the weeds out of the garden. And so if it is the case that that patient will one day develop squamous cell carcinoma, by excising the dysplasia as best as we can, we're at least delaying that sad day until as far away as possible.
Yeah, thank you so much. And then the next from Irvina. Thank you for the chance. Is the degree of dysplasia also affecting the probability of the white lesion to get reversible?
Yeah, so I guess there's a question as to whether dysplasias can be reversible or not. You know, when we think about this question, I want us to maybe use our words carefully. So first we're talking about dysplasia, we're talking about the degree of dysplasia, and then we're talking about the probability of a white lesion becoming reversible. So the first thing we need to remember is that a white lesion can be reversible even if there's no dysplasia. A patient who is chewing on their cheek, they can stop chewing on their cheek, and the lesion will no longer be white. It has nothing to do with dysplasia. It has nothing to do with leukoplakia. And if you call it leukoplakia, well, then it went away, but maybe it's not a leukoplakia. Or the same is true about candidiasis. A white lesion that is candidiasis can be reversed. And so maybe we're asking the question, is the degree of dysplasia also affecting the probability of the leukoplakia to reverse? And that's a fair question. And I think the best way to understand that is to understand that in general, dysplasias do not reverse, because dysplasias develop on the basis of genetic mutations. And DNA that is mutated, it does not become unmutated. It does not become normal again. So typically, once a dysplasia has developed, it's going to, at its own pace, only get worse and worse and worse. Some dysplasias get bad very quickly, some kind of sleep and don't get bad very quickly at all. That process, there's nothing we can do much about. But I mentioned a couple of minutes ago that one of the potential approaches or alternatives to surgery is immunotherapy, which is a type of chemotherapy that harnesses or uses the patient's own immune system to target or destroy the leukoplakia. The only reason why immunotherapy might work, and the only reason why it does work in other cancers such as melanoma, is because the immune system does, our own immune system, it does to some extent possess the ability to destroy precancerous and cancerous tissue. And so it is possible, although it's very rare, it's possible that a dysplasia can regress, shrink in size, if it has some characteristics which alert the immune system to attack it.
Okay. Yeah, thank you so much for that answer. And then, yeah, lots of thanks from many specialists and many dentists for your presentation. The next one from Dr. Carlina. In the case when the patients are hesitant with biopsy, are there any guidelines for how long we should follow up, how long we should observe? Because we have seen from your presentation, there is one case that just for 1 year, the hyperkeratosis turns into malignant lesion. So in the case where, because of financial or insurance system, the patient is hesitant to do biopsy, yeah, what is the guideline for observation or follow-up?
Yeah, unfortunately, there are no guidelines that I am aware of. You know, I give you a talk on leukoplakia, but you could probably bring somebody else in from leukoplakia to give a talk, and they would give you a totally different talk. And I showed you all the definition, the World Health Organization definition of leukoplakia. And it's a very confusing definition. If you just read it, you try to explain that to your child, they will not understand it. It is not a clear definition. It's not something that isn't something with a questionable something. And so we really struggle as a profession to define leukoplakia. And if we can't do that, then we're going to have a hard time administering guidelines. I really do think that the definition of leukoplakia is not difficult. It is dysplasia. It's the appearance of dysplasia from its mildest to its most severe form. And so in the absence of any guidelines, I just think the percentages are helpful. 1 to 3% of leukoplakias undergo malignant transformation annually. The overall malignant transformation of these biopsied leukoplakias, it seems to be somewhere between 5% all the way up into the 20s and not more. And so these are numbers that we can tell our patients. We can simply give them this information and say that this is why I care for you and I want to give a biopsy and I want to figure out what is going on so we can make the best decision for your health. And we can try our best in the absence of any guidelines to compare what we are doing to what doctors in the other parts of the body who are more organized and have better guidelines than us, what they are doing.
All right, we are approaching the final, some final questions. I think I'm stopped at 10:55 Makassar time. Okay, so 4 more minutes. So Dr. Ivan, if the excision is not necessarily needed to do in the cases of leukoplakia, how long do we need to suggest the patient to come again for monitoring? And after how long of monitoring, you can predict this leukoplakia won't develop to malignancy? Maybe just...
Yeah, that's a difficult question to answer. I would probably change some of the words of your question. You're saying if the excision is not necessarily needed. In my opinion, there's no leukoplakia for which an excision is not necessarily needed. I do think there are leukoplakias for which an excision is not possible because of the size or the comorbidities. And so it may be that you and I have some different opinions, and there are different opinions on leukoplakia. But I will agree at the very least that it is not possible to excise all leukoplakias. And again, guidelines are not well developed. But in my opinion, a leukoplakia has at least a 5% chance of becoming cancerous, which is significant. If you had something in your mouth and there was at least a 5% chance of it becoming cancerous, maybe 1 or 2 or 3% a year, what would you do? How often would you like your colleague at the Faculty of Dentistry to look into your mouth? Would you ever feel like comfortable with no longer going to see your colleague, or would you always want them to check on you? These are difficult questions to answer. But I think that the wisest thing we can do for our patients is to continue to follow them up every 3 or 6 months to see what exactly is going on and if there are any changes that we can address for their benefit.
Thanks, Dr. Ivan. And this is the last question for today. How about your opinion about vitamin A to treat mild leukoplakia hepatitis? Some vitamin A has keratolytic effect.
Yeah, this is a difficult question to answer. It's a good question. I'm not familiar with the data in terms of how exactly vitamin A impacts malignant transformation rate. But I can tell you from a biological standpoint is that epithelium, just like any other tissue, there is a small number of epithelial cells that are stem cells. And the rest of the tissue is the progeny or the offspring of those stem cells. And so in order to remove or to kill a dysplasia, we need to eradicate those stem cells. If we administer some sort of a medication, whether it's vitamin A or whether it's immunotherapy, and if that medication destroys the vast majority of the mutated cells, but it does not destroy the stem cells, then the whole tumor will be able to repopulate. That is actually in melanoma and in other cancers, that is the main reason why cancers will fail therapy, because there are certain cells, there are certain cancer stem cells that are able to overcome the treatment and repopulate. You can think about it like, I don't know, the garden or maybe the grass, you know. If you want to get rid of your grass, you don't just cut the grass very, very short because it will grow back. You need to pull the grass and pull the weeds out. Now, I don't know enough about vitamin A to know the specifics of how it works, but if it's exclusively having a keratolytic effect, it can damage and destroy many of the keratinocytes, and the stem cells can still repopulate the dysplasia. So the question is, with vitamin A, with immunotherapy, how can we remove the stem cells? We know how to remove it with surgical excision. You just take the whole thing out of the body and it's gone. But if we want to pursue a pharmacological approach, and I think it's a good idea to pursue it, we really need to be thinking about how to target these stem cells. Good question.
All right. So we are already at the end of this question and answer session. So really, thanks once again, Dr. Ivan Stoyanov, for giving your time and your valuable insights. And I think the take-home message for all of us is really to be very careful with especially non-reactive hyperkeratotic lesions on the mouth, and really aware that it really has malignant transformation around 5%, and we can consider those lesions as mild dysplasia. And yeah, maybe we can remove that so that we have to remove that so that we minimize at all risk possibility to become cancer. Am I concluding it right, Dr. Ivan? Do you want to add a bit of conclusion?
No, I think that you said it terrifically.
All right. So thank you so much, Dr. Ivan Stoyanov, again, for your time and your presentation. And the committee will give 10 best questions, the package from our sponsor, OxyFresh, for this morning. So I give it back to you, Dr. Israyani.
Okay, thank you, Dr. Hedwin. Thank you, Dr. Ivan, for your great presentation. And ladies and gentlemen, distinguished participants, now we're going to announce 10 best questions to get 10 bottles of OxyFresh fresh bread from PT OHW Indonesia. And they are, for the first is Dr. Gigi Chandra Nugraha, Wahyuni, Agustina Maria Isolin, Ananda Nurul Fadilah, Dr. Gigi Dedi Ariwansa, Wahna Lumbangao, Maslah Siregar, Karlina Puspasari, Anzani, and Kurnia Hayati. I think the last question is best question maybe, yeah? Because it's difficult to answer, the Dr. Ivan said. Okay, please, for 10 best participant with best question in this meeting, please contact our team, Dr. Ernie's number. I will put in the chat box. Okay, for who's the I mentioned your name, please contact Dr. Ernie. And so, ladies and gentlemen, that's all our main session. And thank you again for Dr. Hedwin for your kind leading this session. And so we are now going to certificate submitting for our speaker and our moderator today. And giving the closing statement of this program that will be delivered by Dean of the Faculty of Dentistry, Hasanuddin University, to Mr. Muhammad Ruslin, DDS, Master of Health, PhD Specialist of Oral and Maxillofacial Surgery, Consultant. Please, the floor is yours.
Thank you very much for the Mr. of Ceremony. It's, my sound is here. You can hear my sound? Hello?
Yes, it's clear, Doc.
Yeah. So we would like to give inspiration to our excellent speakers for the Professor Ivan Stojanov. And this is we hereby deliver your certificate. And again, thank you very much for your excellent lectures about Czechoslovakia. And I hope we can meet, and we would like to invite you come to Indonesia when pandemic is already gone. Again, thank you very much. And also, we would like to give a certificate to deliver certificate to the moderator, to Dr. Theodoris Hedwin Kadrianto, DDS Oral Medicine Specialist. Thank you very much for your time, Dr. Hedwin. Excellent moderator.
Thank you so much. What a blessing.
Yeah, and
thank you.
Yeah, today we would like to close this event, and Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and good afternoon, everybody. The honorable our speakers today, excellent speakers, Associate Professor Ivan Stovanov, DMD Master Science, and ladies and gentlemen, and all distinguished participants. Alhamdulillah Rabbil Alamin, all praise and gratitude to Allah Subhanahu wa Ta'ala. We are delighted to have you with us in this event. This event is the 11th Virtual International Symposium series that you for attending. That many of you have joined us here serves as a reminder to us how important knowledge of oral leukoplakia is in the dental practice. Ladies and gentlemen, I have gratitude and respect to Professor Ivan Stojanov as our speaker today, and I hope we can invite you to another symposium meeting in Indonesia, especially in Makassar. And for this time, we would like to gratitude also to the moderator, Theodorus Hedwin Kadrianto, DDS specialist in oral medicine, and also to the Master of Ceremony, Dr. Isra, oral medicine specialist, and to all of organization committee for the effort, high effort to finish this event, to Dr. Ernie with team. Once again, thank you all of joining this scientific meeting and look forward to seeing you again. May we all keep healthy and maintain healthy protocols. Finally, on behalf of Faculty of Dentistry, Hasanuddin University, I would like to express my appreciation to all participants for taking part to these scientific meetings and wishing the next prosperity of our future event. And thank you very much for your attention. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Ruslin, Dr. Hedwin, and also Dr. Ivan Stoyanov for the great presentation and discussion about oral leukoplakia. The session was really inspires our knowledge about oral soft tissue disease and the changes in dental education, especially in oral medicine department. Thank you too for our invited guests for joining today, Central Indonesia's time. Of course, different in another country's time, especially in Ohio, United States of America, Dr. Ivan. Okay, ladies and gentlemen, distinguished participants, now we come to end of the webinar. Allow me, Israyani, and all organizing committee to say thank you very much for your participating and attention in this webinar, and apologize if there is any mistake in this event. And for your information, Virtual International Symposium series held by Faculty of Dentistry will present next month with another topic. Hopefully, we will see you again in another time. Thank you all to your kind attention. Wassalamualaikum warahmatullahi wabarakatuh, and keep healthy and sound.
Thank you.
Thank you all.
Good, Rifan. Thank you all.